Welcome everyone to day 2 of the Neuroblastoma Parent Global Symposium. My name is Nick Bird, trustee of Solving Kids Cancer UK, and I'll be moderating this session entitled SIOPEN ITCC Relapse Strategy and Trials, which has been delivered today by Dr. Pablo Berlanga, consultant in pediatric oncology at Institut Gustave Roussy in Paris, and Dr. Lucas Moreno, clinical director of pediatric oncology and hematology at Vall d'Hebron Hospital in Barcelona. As per usual, a friendly reminder to use the Q&A button at the bottom of the screen to submit your questions during the session. If the button's not showing, just hover your cursor to bring it up. If you see a question you like, give it a thumbs up to move it to the top of the list, and we'll try and get through as many questions as possible. And with that, I'll hand over to Lucas to open proceedings.
Hi, good morning, everyone. Thanks very much for the very kind invitation to do this this presentation. I'm very honored. As you know, I'm a very keen attendee of the Solving Kids Cancer UK Parents Conference, which I've been attending for, I think, more than 5 years in a row now. And even in these tough times, we need to continue. We need to continue working in developing drugs and doing clinical trials so that we can improve the results on our patients. So today we're going to talk about the relapse that we have got in SIOPEN and ITCC, the European consortiums for for clinical trial development for neuroblastoma, and I'll be focusing a bit more on the first relapse trials and the overall portfolio that ITCC has got. So briefly, you can here see my disclosure. And these are the 3 areas that I'll cover today. The strategy to treat relapsed neuroblastomas that we are developing in SIOPEN. I'll touch on the BEACON-Neuroblastoma trial, which is one of our larger trials in first relapse. And then we'll go into discuss the portfolio of ITCC of early phase clinical trials. First of all, I think I wanted to mention that the effort that we are doing and undertaking to have an overall strategy for relapsed patients. I think several years ago, 3-4 years ago, we were all in agreement that outcomes at relapse were really low, and we needed to continue working to improve them. But there was a lot of heterogeneity. There was many different, very small clinical trials being done. And the clinical practice was very different across Europe. And that's where we put together a group of experts that Angelika Eggert from Berlin and myself are leading. And we have been having regular meetings for the past 3 years just to try to come up with an overall strategy, same that we do at frontline with our frontline newly diagnosed patients, where the strategy is very clear. So we all agreed that for relapsed patients with high-risk neuroblastoma, I will not talk about relapses of patients that are low or intermediate risk that can still receive frontline treatment, but all patients should receive a chemotherapy-based regimen. More recently, with the addition of targeted agents, and for example, with chemoimmunotherapy. And we all agreed that molecular profiling was critical, also that every patient could have a biopsy at relapse and have their tumor profile to see if there were molecular aberrations. Although there was overall agreement with this part, but then there was a lot of heterogeneity and a lot of different practices, as I mentioned. So many patients with this treatment experience a response of their tumor, or the tumor stabilizes. So then we realized that we needed to put in order and have a strategy and our ideas for how to consolidate this strategy, or how to give some maintenance treatment, same that we do in frontline treatment. And examples of these are, for example, giving MIBG therapy, or very long-term chemotherapy at low doses, and And the other, unfortunately, at some point on this pathway, some of the patients might experience progression or relapse. And here, the areas of work are to have more phase 1-2 clinical trials available, and also to try to use, if we have identified a target, a gene or a genomic aberration that is present in the tumor, then give a treatment following that aberration that has been identified. So the first area that we started developing is to try to register this activity and develop a guideline, because we have first surveyed the practice across Europe, and it is very heterogeneous. There are very many different chemotherapy regimens or combinations that are being used at first and second relapse. So we will try that is a bit more homogeneous. We will work, at the moment, we have got 2 trials ongoing for first relapse: REAST, that is based in Germany, but also open in other countries like Austria or Czech Republic, and BEACON, that is open in other ITCC countries like France, the UK, Spain, Italy, the Netherlands, and some others. So all patients should be considered for this for the first relapse trials. At the time, because both trials are just about to finish, we are already working on the future relapse trial, and also collecting data from the molecular platforms. As I said, the consolidation and maintenance idea was very interesting, and the people in the German group with Peter Lang and Angelika Eggert were really interested on evaluating the role of haploidentical transplant. That, you know, it has been used in a proportion of patients and is more commonly used in Germany. So we are also trying to find out how to really know if it has a role, and we're working on developing a study in this setting. And then for this portfolio of phase 1 trials, we also had to work on making sure that they are more aligned for neuroblastoma and that there are sufficient trials available. So regarding the BEACON-Neuroblastoma trial, this is an adventure that we started back in 2010, together with Andy Pearson, that was the initial chief investigator of the trial, with Keith Whitley and with Cormac Owens. And when we speak about BEACON, there are actually 2 trials, although it's for regulatory reasons is the same one, but the BEACON-Neuroblastoma that has been running from 2013 to 2019 and recruited 160 patients. So this trial was testing the addition of 2 chemotherapies to temozolomide, the addition of irinotecan and topotecan, and also the role of bevacizumab, an anti-VEGF monoclonal antibody, a molecule that goes against the formation of new blood vessels in the tumors. And then the second part is called BEACON-Immuno, that we're doing with Juliet Gray from Southampton, where that is currently ongoing, and it started last year. And we are evaluating topotecan and temozolomide chemotherapy with and without dinutuximab beta and the anti-GD2. So regarding the first BEACON, although the patients got randomized to one of 6 arms, depending on the trial arm or on the chemotherapy arm or on the use or not use of bevacizumab, we are grouping them for the analysis, and we have got the irinotecan randomization, so all patients that got irinotecan versus those that didn't, or bevacizumab randomization, all patients that did get bevacizumab versus those that didn't get bevacizumab. And we don't have results on topotecan yet. So regarding the first results that we have got from this trial, we first looked at response, which is how the tumors shrink, how the tumors become smaller when you give chemotherapy or a new therapy. And we showed that adding irinotecan did not improve, did not make the tumors shrink more, but it was more toxic. It added toxicity. We also learned that adding bevacizumab did improve response rate. More patients had a response and their tumors shrank by giving bevacizumab, and that met what we call the trial success criterion, what we had predefined that it would be a successful trial. But it also added more toxicity. This year, we are analyzing survival, and here we see survival curves for progression-free survival. This is the time that the patients take until they develop a new relapse or a new progression. And we see clearly that irinotecan, adding irinotecan, improves survival, even if it does not shrink the tumors, but the patients spend longer time without growing, without their tumors growing. And bevacizumab has some positive effect, but is not so remarkable. And then because of this complex trial design, we are also looking at the individual arms. So the patients that got temozolomide alone, or bevacizumab temozolomide, irinotecan temozolomide, or the 3 drugs together. And it seems that those that got the 3 drugs together do better, but we are still waiting for some more data to have a conclusive result. Regarding BEACON-Immuno, as I said, this is the randomization to get topotecan temozolomide chemotherapy or with dinutuximab beta. The majority of patients, double the patients, are being randomized to getting chemoimmunotherapy, and still those that get chemotherapy alone can cross over to the dinutuximab beta arm when they develop progressive disease. We are just about to complete this randomization because there was great interest from the community to for this trial. So in 1.5 years, we have recruited pretty much the whole trial population, and we are hoping to complete the trial later this year or beginning of next year and have the results by the end of next year. So in summary, BEACON has provided us with randomized evidence about the role of irinotecan, bevacizumab, with improvements in survival for relapsed patients, but we still need some more data that we'll have during this year and beginning of next year, with more follow-up to know about topotecan and see if there is a difference on relapsed and refractory patients. At the moment, we are waiting to complete, or just about to complete, BEACON-Immuno and RIST, the German trial, and this will inform the design of the future trial, which we're already working on it, considering definitely that we will want to incorporate chemoimmunotherapy, bevacizumab, the RIST regimen if these results are positive, and considering new arms, for example, with the addition of anti-CD47, a new form of immunotherapy, or other targeted agents that we are developing. So with this, I'll move to the portfolio of trials in ITCC. So this is quite a long list, and I don't want to go in detail onto the list of available trials. Every time that one clinician has a patient that would be a candidate for this, they are used to contacting the ITCC network and finding out how many are available or where are they available, because they tend to open and close quite rapidly. I mean, overall, the trials that are available are for ALK-positive neuroblastoma. There is the CRISP trial and the Lorlatinib trial. There are a number of targeted agents, some of them with a neuroblastoma focus, like an aurora kinase inhibitor, a CDK4/7, BCT100, that is a trial developed in the UK, a BCL2 inhibitor, Nivent, that is a combination of nivolumab with entinostat, an MDM2 inhibitor, and then other trials that are more generic for all types of patients with solid tumors. And then immunotherapy trials. We will hear during the conference on trials on naxitamab and on omburtamab for CNS relapses. And there are other trials with immunotherapy for all patients with solid tumors. I think I just wanted to remark that year by year, so the progress is still slow and we want it faster, but there are more trials on more targets. More of them are neuroblastoma driven, and more of them include combinations, and more of them include phase 1B or phase 2. They're more advanced in their development. And I just wanted to briefly mention a discussion we had at the beginning of earlier this year at ASCO, because many of the new trials that are being reported now, this is one of our bigger conferences, they are combination trials. So and this is a very positive step, that they're not just drugs given in isolation with very low chances of working. And for example, out of the ones that I have mentioned, venetoclax, idasanutlin, the aurora kinase, abemaciclib, Nivent, they are all being developed in combinations. They are all highly attractive novel agents and interesting combinations that are being developed, both novel agents with chemotherapy or novel agents with other novel agents. But we are finding more toxicities. We are finding that some of these drugs are very difficult to give in combination, and we are having to pause the trials and trying to understand better how to give these drugs together. So the trial design is also evolving. We now have much faster dose determination, and we go into expansion and combinations more rapidly. We have less of single agent trials. We still see that non-biomarker driven, so trials that are not based on a biomarker, on a gene aberration, are still appealing. There are epigenetic therapies, there are therapies targeting apoptosis, angiogenesis, so not all patients will have a target, or some targets that we find will not have a drug that is readily available. So still, these trials are very relevant for the biology of neuroblastoma, and we have great interest on seeing their results. But with this, so this is a great combination that we have non-biomarker driven approaches, so trials for all relapsed neuroblastomas with immunotherapy or other broader therapies, and then biomarker driven trials, which is what Pablo Berlanga will be talking today. So with this, I'll acknowledge all the great team that is helping with the BEACON trial, the charities that supported us, and the companies that provided the drugs. Thanks very much. I'll hand over to Pablo and look forward to the discussion and having many questions discussed. Thanks a lot. Over to you, Pablo.
Thank you, Lucas. So thank you very much to Lucas for handing the session to me, and also for the organizers for having invited me to this talk today. So compared to Lucas, I'm new, so this is the first year, and it's a real pleasure to be able to share with you the next minutes to discuss about the second relapse ITCC trials strategy and SIOPEN, and the incorporation of target therapies to SIOPEN frontline treatment. So I'm pediatric oncologist working at Gustave Roussy, and I have nothing special to disclosure. And what I would like to discuss in the next 10 minutes, more or less, is about SIOPEN second relapse strategies, the SMART trial mainly, and also how to incorporate target therapies or new agents in the front line. So I think that I took this slide from Lucas. I think that the important thing is to realize at the time of relapse that the options in the case of first relapse are more straightforward, which is the inclusion right now, for example, in the BEACON-Immuno trial in SIOPEN. But it's true that the options in case of a second or further relapses are less clear. And for that, we really need what Lucas said before, a molecular profile performed, if possible, at the time of the first relapse to be able to better guide treatment in case of a second or further relapse. So this is not just for neuroblastoma, this is the global ITCC strategy for all patients that have a relapse. And for example, here you have on the left the several molecular profiling programs that are currently ongoing in Europe. I belong to the MAPI-ACTS program, also Lucas, that has been performed in France, Spain, Italy, and Ireland. And the results were shared last year in ASCO, and we are ongoing the publication now of the results. And it's important to realize that in this type of molecular profiling trials, we are able to identify in more than half of the patients a potential target. But it's really important to realize that most of those targets are not of unknown I mean, some of them do not have treatments that can be given to. Some others have treatments, new target therapies, but for most of them, we do not really know which is the possibility of response to them. So for example, right now, for neuroblastoma, in the case of neuroblastoma, we have ALK as a target, but for the other targets, it's very important that patients are included, if possible, in trials to be able to generate this information and to really know which is the potential response of these patients that have these alterations in the tumor. So important to, in case of first relapse, try to perform a molecular profile that is currently a standard in most of the European countries at the time of relapse. And that can help in some of the cases to better define the strategy in case of a second relapse. So Lucas has very well presented the ITCC portfolio. I just wanted to share with you one slide of the ESMART trial. So the SMART trial is an academic trial that is the work of many countries and many centers together that aims to cover the targeting of several survival pathways in oncogenesis that were currently not adequately addressed. So the idea of SMART, so it's a basket trial in which there are several different arms that run independently with different biomarker selection or not biomarker selections in some of them that target several survival pathways. It was open in 2016. Now it's open in France, Netherlands, Spain, UK, and it's going to open next in some other European countries. The inclusion criteria is to have less than 18 years of age at the time of inclusion, to have at the time of initial diagnosis, to have a molecular profile at the time of relapse, to have a relapse. Of course, this is not just a neuroblastoma specific trial, it's for all patients that have a relapse. And I think that one of the main beauties of this protocol is that it's a dynamic protocol that allows to open and to close new arms with the time. So for example, here you see on the right, since the opening of the trial in 2016, there have been several modifications of the protocol. Initially, there were 7 arms. Then we opened 2 years ago 3 more arms, and right now we have just going to open 5 new arms. And for example, in the case of the new 5 arms that are going to be open, there are some of them that were in the list that Lucas presented before with cell cycle inhibitors, with CDK4/6s, with DNA repair inhibitors that are of interest for patients with neuroblastoma in case of a relapse. So, but what we've said is how can we improve treatment at the time of disease recurrence? But another point is how can we reduce the number of patients that do not respond to first-line treatment or that sadly relapse. So the idea is to see how can we, with the knowledge that we have got from the relapse setting, how can we improve what we do in first line for our patients. And this is why I will briefly introduce the incorporation of anti-GD2 and ALK inhibitors in first line. So I think that some of you will be familiar with the current high-risk neuroblastoma strategy in SIOPEN. So there is now a phase 3 trial in Europe. There is the high-risk neuroblastoma 2 trial that is currently open only in France, but that will open next in most of the SIOPEN countries, in which we give an induction chemotherapy. It's a randomized question between the previous induction chemotherapy in SIOPEN, that it's a rapid COIEC, versus the GPOH, the German induction chemotherapy. It's a randomized question. And then at the end of the induction chemotherapy, patients receive an adapted strategy based on the metastatic response to the tumor to the previous treatment. So we know that around 70% of the patients will have a good metastatic response that will allow to continue on the protocol with high-dose chemotherapy, local treatment immunotherapy. And in those cases, we also ask another randomized question that is the standard of care for these patients, which is 1 high-dose chemotherapy BEMEL versus 2 of tandem high-dose chemotherapy. But we also know that sadly there are 20–25% of patients that may respond but do not achieve enough good response to continue with the previous treatment. And for those patients, we have the VERITAS trial, which is a specific trial to try to improve the prognosis of these patients that do not have a good response to the induction chemotherapy, good metastatic response to the induction chemotherapy. And the VERITAS trial is also open in several European countries that gives chemotherapy and gives tandem high-dose chemotherapy versus MIBG, therapeutic MIBG with BEMEL, and also local treatment and immunotherapy. And of course, we know that sadly there are 5–10% of patients that may even progress with induction chemotherapy. So the idea is how can we improve this data? How can we improve the response of these patients in first line? So there are 2 options that are currently on work in SIOPEN, anti-GD2 and ALK inhibitors. The first is the chemoimmunotherapy proposal that we are testing also in the relapse setting. The idea is not just give dinutuximab beta in the maintenance treatment, which is now standard of care, but try to combine that with induction chemotherapy. That we know that we think that may increase the response rate of these patients and may potentially also increase the prognosis. So this is an ongoing proposal that is still on work with EUSA, that is the owner of the dinutuximab beta, and it's Holger Lode, the PI, the chief investigator of the trial, and we hope to be able to hear some more things of this trial in the next future. The other target therapy, then the other agent that can be incorporated to first-line treatment is the ALK inhibitors. So why talk about ALK inhibitors? First of all, because we know that in newly diagnosed patients, around 10% of them will present an ALK mutation in the tumor, and 4% of them will present an ALK amplification in the tumor. With the data of SIOPEN that was presented last year in a SIOP Congress, the European Congress, International Pediatric Oncology Congress, we know that patients that have an ALK mutation or an ALK amplification on the tumor at initial diagnosis, they do worse than the other population, as you can see here on the graphs, as the other patients that do not have any ALK abnormality on the tumor. And also because we have agents that specifically target ALK. It's true that there are several agents, first, second, third generation. For example, the first generation was crizotinib, that I think these data were presented yesterday by Yael. So with a limited activity, but activity anyway in some of patients. So this was presented and published 7 years ago. There were some data showing that combining ALK inhibitors with chemotherapy could improve the response rate and the prognosis of these patients. So this is why some years ago, COG, our American colleagues, decided to incorporate an ALK inhibitor in frontline in their phase 3 trial for newly diagnosed patients that was open 2 years ago. At that time, we had some discussions in SIOPEN, but we thought that the toxicity of crizotinib alone, a single agent, was too high and too overlapping with chemotherapy because it was mainly hepatic toxicity. So we thought the results that we have on efficacy and the potential toxicity combination of crizotinib and chemotherapy may not be the best option for the SIOPEN group. So we decided not to include this ALK inhibitor in the high-risk protocol, but things have evolved in the last years, and we have second and third generation ALK inhibitors like ceritinib, with 20% of the patients that have their tumor shrink with that tumor at the relapse setting, and also, and more interesting, the lorlatinib, with also around 20% of the patients that benefit in the relapse setting, that is usually, that is well tolerated and that does not have overlapping toxicities with the chemotherapy that we give in newly diagnosed patients. So right now, we think that this ALK inhibitor, based on the preclinical data, the data that we have in patients that have been treated in relapse, the data that we know about the toxicity, may be the best options for the patients that have an ALK aberration. And it's a ongoing work of the collaboration with SIOPEN and COG. So COG is modifying or amending their protocol to change crizotinib to lorlatinib, to switch the already arm they have with crizotinib to lorlatinib, and the high-risk 2 protocol of SIOPEN is currently under amendment to be able to introduce this ALK inhibitor in first-line patients that have an ALK aberration on the tumor. So the idea is that in the high-risk protocol in SIOPEN, the idea is that patients will be included in the protocol, offer the current first randomization, rapid COGEC GBOH. Their tumor will be analyzed quickly in the SIOPEN reference labs with the idea to have an ALK status, to know the ALK results on the tumor before 3 weeks. That way, those patients that have ALK alterations that are expected to be 10% or between 10 and 14% of the global population will be offered the inclusion in this arm that will be given in combination with the current SIOPEN high-risk treatment, that is a rapid COGEC. And then, of course, depending on the response, only those patients that progress will not continue the trial, and then will go to the trials like BEACON-RIST, as Lucas presented, and those with good response or insufficient response, but still response to the previous treatment, will continue, as you can see, with the current SIOPEN standard of care. So right now there is a funding that request that it's ongoing to parent-led charities, to Pfizer, that is the owner of the Lorlatinib. There is a statistical design ongoing to merge data from both trials, because the idea is that we will run on parallel both trials, COG, SIOPEN, and at the end we will combine, so we will run them both in parallel with similar rules regarding toxicity assessment, efficacy, with the idea to be able at the end to merge the data of both trials and to get the results as soon as possible. And within SIOPEN, we are working hard to try to have this amendment available at beginning mid-2021 and to be able to recruit patients mid-2021. So I would like just to thank all the people that have been working in these protocols and these trials, like the ESMART trial, mainly Birgit Georger, which is the first on the left, that is the PI or chief investigator of this trial. And here you have many of the PIs of the main trial arms. Also the people involved in the pilot trial, and very special thanks to all the SIOPEN colleagues and the COG that have been working very hard to put together the SIOPEN and COG collaboration in patients with ALK abnormalities. And I think it's a very special thanks, because I think it's an important thing that we are able to work together like this. And all of them are really not just brilliant scientists, but also wonderful people that I'm very proud to work with. So thank you very much, and happy to take all your questions.
Thanks, Pablo, and thanks, Lucas, for your talks. We do have some questions. So the first question that comes in is about a recent paper published in Germany on 2 difficult relapse refractory cases using an off-trial combination of antibodies, nivolumab and dinutuximab. And the question is it being considered at all for a trial? And if not, can anybody get access to this treatment off trial?
Yeah, thanks for the question. We have seen the publication and have looked at it. We have considered the addition of anti-PD-1 agents to the first relapse trial. At the moment, the results of the anti-PD-1 agents in pediatrics alone as a single agent have not been good. They have been developed in adults, being tested in all the adult tumors, and some of the adult tumors have responded. And a similar strategy was started with pediatric tumors being tested in significant numbers of patients without responses. So what we really need is the laboratory studies, the preclinical studies that tell us which patients could really respond to the anti-PD-1 agents and how to combine it. So that is ongoing, and for example, that's part of the work that Juliet Gray from Southampton is doing. And when we have more specific data of which patients can benefit and which combinations, we will definitely consider that. I mean, the publication is encouraging, but it's still a small number of patients. As far as I know, already this is being tested in combination in the Minivan trial. This is a trial that is open in the UK, in Germany, and the US, that gives MIBG therapy with nivolumab and with dinutuximab beta to patients with relapsed neuroblastoma. And that trial is ongoing, and definitely we will consider other combinations. Regarding access, that definitely depends on the clinical team that is looking after each individual patient, and there are hospitals and countries that have more or less limitations to access targeted drugs. I mean, I would strongly recommend discussing it with one of the centers that have more open clinical trials to see if a clinical trial is available first, and then discuss it with your local clinician.
Thanks, Lucas. So next question. It's good to see trials available for relapse, but what about children who are chemo resistant? So I would like to know what's available in the future for children that are chemo resistant that's not chemo based. So why are all the trials, even in combination, still so chemotherapy based when so many children prove to be chemo resistant?
Yeah, correct. I mean, the refractory neuroblastoma is a whole different group of patients, and we have focused today on relapse patients, but definitely there is a great need of new treatment strategies for these patients with refractory disease. The fact that they are refractory to the frontline chemotherapy doesn't mean that they can be sensitive to other chemotherapies or combinations. And because some of them respond to second line chemotherapies, that's why the first thing that we try is to give chemotherapy with other agents. And that's this is in the line of the Veritas trial that gives chemotherapy and then is followed by a consolidation, as Pablo was mentioning. There are the BEACON trial was testing bevacizumab for this patient, is now giving chemoimmunotherapy, and same with chemoimmunotherapy being given in the trials done in the US by the Children's Oncology Group, by St. Jude, and by others. So there are parallel efforts on the clinical trials, and then we are developing the first relapse or first refractory clinical trials. We are developing also novel combinations, as you have seen in the presentation. There are combinations that don't necessarily have chemotherapy, and at the same time we are learning more about the biology of neuroblastoma. So we know that many of these patients have aberrations like ATRX mutations or others that at the moment we cannot treat, we cannot target, but that is work in progress to find better drugs. So it's probably a triple approach, obviously, and understanding that the results of this population are also also need a lot of improvement.
I think that it's important to say, I mean, to realize that we have to be humble, and for the moment we are not able to identify at the beginning of the treatment which are the patients that will be able to respond or not to chemotherapy. So that for the moment it's not feasible. So it's why it's really important to improve the knowledge of the biology, to do the molecular profile if feasible at the time of the relapse, because that's the only way that in the near future we will be able to improve things that we are doing right now. But so far, we are not able to identify those patients that will respond to chemotherapy, those that will not, neither at initial diagnosis, not at the time of relapse. And so far, sadly, chemotherapy still is the best treatment option for the patients, even if we have many target therapies, but for the moment, they are not so promising for the moment.
Do you think we will ever get there? I mean, BEACON is trying to select the best chemotherapy backbone, but still some children will not respond to one chemotherapy combination, but they will respond to a different chemotherapy combination. Is there any research going on to try and figure out why that might be?
Well, yes, there is. I mean, there is research on the, as I mentioned, on the biology of neuroblastomas and which neuroblastomas are more refractory. And then in the BEACON trial, and there are other efforts in NANS and by COG, etc., trying to identify which patients are going to be refractory right from the beginning, and then also with the samples that we have got in the BEACON trial, for example, we are going to start analyzing them and try to see if there are markers or factors that predict which patients are going to be refractory or why these patients are refractory. So there is work ongoing, and hopefully we'll in 2 or 3 parent conferences we will have some more good data to present.
So I think this is probably another one. So BEACON-Immuno, and then I know this is really important to parents. So in a future trial design, will it enable children to access the chemoimmunotherapy arm straight away, or will this too still be randomized? So we understand the importance of the crossover, but to wait for disease to progress before crossing over is very difficult for families.
Absolutely, is a very clear point, and we were very much aware of this situation when we started the current trial. The reason for doing the current trial or the current trial design is that as we all agree that chemoimmunotherapy is promising and is a good therapy that we want to bring as upfront as we can. but experience tells us that if we want that all patients have access to the chemoimmunotherapy now and in the future, and we need to convince the regulators, we need to convince the healthcare systems, we need to convince the clinicians. So we do need a very clear answer. So that's the reason why it has to be a randomized trial. For the future trial that we are considering, we are hoping that the aim is that all the arms have good chances of working, as of course in all the trials, and we are trying to get away from chemotherapy alone. We are trying that all the arms incorporate novel agents that are promising, but it is a difficult balance. We do want the trial to be randomized because it is the way that gives us the best evidence. But it is very difficult that all the arms have exactly the same results. And if you want to bring in innovative therapies, there is less data from the drugs that are more innovative. So it is a balance that we are definitely trying to keep. We are trying to get away from the chemotherapy alone, and trying to balance that the arms have the best possible results, and we do, but at the same time develop innovative combinations, because if we don't bring in innovative therapies, then there's no way to improve even beyond what we have. But we're waiting for the results of the ongoing trial, but definitely keep in mind that we need to offer the best chances to the patients that participate on the trial, because it is even if the crossover is better, it is still not ideal.
One for you, Pablo. Have any children with neuroblastoma, to your knowledge, been treated with TVEC as part of the ITCC solid tumor trial?
TVEC?
The oncolytic virus. I think that is an ongoing trial, so we don't have the full results. Not to my knowledge. It's just these TVEC, this oncolytic virus, you need to inject it in the tumor. And for that reason, it's quite difficult to enroll neuroblastoma patients, because the tumors are generally in difficult places. They are abdominal, retroperitoneal, they're in the thorax, they're in the bone. So, I mean, because this is the first-in-child trial, the study is quite restrictive on which lesions you can inject. So I believe it's more sarcomas that are being treated, because they tend to be more on the extremities and they are easier to access. I mean, I am aware that there is a group in Madrid developing an oncolytic virus that is given intravenously, and that's still work in progress. But at least that one, because it's given intravenously, it's easier to administer, and it is being taken forward to a phase 2 trial that hopefully will open soon.
Okay, we've got a couple more minutes, so I'm just going to try and get through a couple more questions before we have to close the session. One for you, Pablo. Is there the ALK study that's open at the Royal Marsden? I don't think it's open at Institute Curie. It's closed at the moment. That's not due to the amendment that you were talking about in frontline.
No. So it's independent. So the Lorlatinib study that is open in Royal Marsden, it's expected to open also in France. It's not Gustave Roussy, but Curie. So they should be open in the near future, and it's in the relapse setting and also in combination with chemotherapy. So there was a part that was just single agent and then combination with chemotherapy. But I think that right now there is enough evidence in case of a patient with ALK mutated tumor in relapse to try to discuss, maybe according to the country, according to the institution, I mean, if it's possible to get even that treatment in a compassionate use. So I think that it's so we have the crizotinib, ceritinib, lorlatinib trials. I think that evidence is much lower for the patients that have an ALK amplification, but for the patients with ALK mutation, I think that could be feasible. What is also important is those things that are done outside trials, that we properly correct the data. So, for example, in France, we have a registration in which we register patients that receive target therapies outside trials in a compassionate use, to be able to, at the end of the day, know which is the response.
Thank you, Lucas. Pablo, apologies for the questions that we didn't get to. We will very much attempt to answer those either via email or in another session. So bringing this session to a close, up next we have Seeking a Second Opinion and the REDMAP study, and then in parallel, Being a Teenager, a Young Adult on Treatment. They're running concurrently if you head back over to the Watch Live page to start viewing, and I will see you all later.
Thank you. Goodbye.
Thank you. Bye-bye.